All right, well, we're going to begin with the examination here. So first we're going to start off with his upper extremity reflexes. So first one is C5, which is the biceps. So I'm going to traction. Okay, so that's 2 plus. That's 2 plus. And next is C6, which is brachioradialis. So 2 plus. There we go. Just relax. There we go. Okay, 2 plus. And then triceps is C7. So put his hand on his hip. Behind the triceps here. Okay, 2 plus. All right, 2 plus there, and then C8 is the finger flexors. This one's kind of hard to tell, but actually I'm getting a little bit there. And then 2 plus for those. Next is upper motor neuron involving the inverted supinator sign. So do that bilaterally. So I'm going to have him pronated slightly, stipwise with this. And then we're going to tap just proximal to the styloid process. So that's a negative test. If it was a positive test, his fingers would kind of clench like a fist and extend slightly as well. All right. And then if he had a positive, that possible condition that would lead to a positive test would be ALS. Final pose for patient. Okay, so I'll have you go face down for me, please. T6. T6 is left rotated with right lateral flexion applying torque. So non-spinous contact. So I'm going to find T6 by going to the inferior angles of the scapula, coming midline. That would be on T6. So I'm going to just come laterally. He actually has this. So I'm going to put my piezoform on his transverse process, his left transverse process of T6. And I'm going to torque counterclockwise, correcting for the lateral flexion, and then I would have a patient take a deep breath in, out, and then I would impulse there. All right, you can get up. All right, examine the shoulder for internal rotation restriction and demonstrate a corrective supine stretch adjustment. So head rest up here. Okay. So then I'll just assess the shoulder I'll just do this shoulder. So assessing for internal rotation, checking for when his shoulder kind of comes off the table, and that's kind of the end range of motion. So that's about there. So if he was deficient, I would kind of have him rest his arm on my leg so I can apply my elbow to get an extra little bit of leverage there. I'm going to use both hands. I'm going to traction into internal rotation, and then apply my elbow under my knee to get a little bit more, and then I would distract slightly and then impulse doing a quick internal rotation adjustment. All right. Demonstrate evaluation of the lunate for posterior to anterior restriction. Set your final pose. Okay, so for the lunate, I would just have him flex and extend. The lunate kind of sinks in when he's in extension and kind of pops right back up when he's in wrist flexion. So I find the lunate there. So he has a posterior to anterior restriction, so I'm going to apply a P to A force. I'm going to put my thumb directly on the lunate. My other thumb is going to cover it, and then I would have patient lean away from me, and then I would quick do a pronate or a ulnar deviation with my wrist to apply a P to A thrust to that lunate. or I guess I don't know if I did the actual final pose, but I'd lean away, and then right here, and then I would impulse. Okay. Evaluation of the TL junction for extension restriction and show an adjustment for this problem with patient seated at the end of the. So for the TL junction for extension restriction, yep, let me go to the end of the table there, and then I would, I don't know, maybe I have to flip around so that you can actually see. Look how that works. So I would just find the TL junction, kind of hook, push them into an extension, and then I just using a pincer grip, pushing into extension to test throughout the TL junction. Okay, flip around, give yourself a hug there, and then I'm gonna have patient kind of crunch down so that when I lean him back onto the table, that his low back will be what's on the table, so that'll actually get the adjustment. If I had a thoracic board, I would use that to help aid the adjustment. So I'd be just putting my MCP contact onto the spinous of wherever I felt, let's just say T12, if that was the one that had the extension restriction. So then I'd have a patient take a deep breath in, tuck his chin, and stay in that crunch position, go down, and then thrust. Let me back up. Evaluate for internal rotation restriction of the hip and demonstrate your final pose long axis. Okay, so I'll have you go supine again. So let's say, so I'd only do this type of adjustment on a patient who doesn't have any knee, foot, or ankle problems. If it was an elderly patient that would possibly have any suspicion of osteoporosis, I also would not do this specific type of adjustment. So evaluate for internal rotation. Actually, I'll flip you, go prone, so then I can just check the internal rotation. So just bring his knees up to 90 degrees and then just have him fall out to check for internal rotation. All right, and then you can flip back over for me, please. So if this one was more restricted, I would kind of turn his foot in so that I'm applying an internal rotation force through the hip there, and then make sure to keep my chest upright, my core strong, that tug of war position, and I would just, like I said, internally rotate and then along axis, and then once I feel that endpoint, then I would tug it quick and give it a quick impulse for an adjustment. Evaluate for A to P glide of the fibular head to demonstrate your final pose for PA. Okay, so I'll have you flip over prone for me. So if a patient can't get their knee past 90, bring them up to 90. And then I'm gonna kind of come on his calf and then curl so that my pisiform contact will be right on his fibular head, putting his foot up against my shoulder. Again, I'm going to come around so that I can apply that traction onto the fibular head, and then I would traction up slightly, and then I would just give it a quick P to A thrust through the pisiform contact on the posterior side of that fibular head. Okay, evaluate for internal, external flexion, extension, restriction of the first MCP. All right, I'll have you sit up for me, please. So for his first MCP, I'm going to stabilize the metacarpal here, then just checking for thumb flexion, extension, internal rotation, external rotation. So if I was to do an adjustment, I would apply distraction along the long axis. If we had an extension restriction, I would traction out, and then I would go dorsal to ventral, applying a quick impulse there. If he had flexion issues, I would distract out and go ventral to dorsal. If he had internal or external, I would again distract and then turn in and then impulse either way, like that. And then the last one, evaluate for normal muscle strength of L4, L5. Okay. So I'll have you stand up, just make sure that I can actually see you. Okay. So for L4, I'll have patient walk on his heels and turn his feet inward. Testing for L4. And then for L5, I'll have him lift up his big toes off the ground and then lift his feet off the ground and then walk towards me while trying to keep that big toe off the ground, just like that. Perfect. And then you can just turn around there. And then for S1, have patient go up on his tippy toes and then just walk away from me. This is testing S1. All right.